Good morning, everybody. Today's CCR we are doing from Department of Surgical Gastroenterology, and this department has been established for a long time in our institute and in Rajasthan for a significant time now. And just to introduce our department, we have two professors and one associate professor. We have had three batches already passed out from our institute. That is, the first one you can see they are presently working in Shalby at Ahmedabad and Asaram Medical College at Eluru. The second batch at Vadodara and Ahmedabad, and the third batch has recently passed out, and both have been busy with their marriages and honeymoon, so they will be joining very soon now. So our basic area of interest of surgical gastroenterology is in laparoscopic surgery, robotic surgery. We expertise in the area, specifically in the area of GI malignancies, complex hepatobiliary surgeries, liver resections. We do a vast majority of large, complicated incisional hernias, retroperitoneal tumors, complex tumors, and our team actively supports in the transplant program of HPB surgery. We have conducted a large number of gallbladders, interstitial colorectal surgeries, pancreatic surgeries, which is our area of interest, gastroduodenal surgeries, and the other areas. We were the first to do the robotic fundoplication in Rajasthan, and first robotic bariatric surgery was done by our department from surgical gastroenterology. We have a comprehensive, very academic schedule that is from Monday to Saturday, that we do it in collaboration with the Asian Institute of Gastroenterology, the PG clinics on Mondays. Tuesdays we have a case presentation. Saturday is Jaipur surgical tutorial, that is a regular feature. We have been having under Jaipur surgical tutorials the master classes on regular basis, which have been viewed online by enormous number of students. We have majority of these programs are being done by my teacher, my mentor, Dr. B.K. Kapoor sir, which has been done very actively and rigorously. We go to for the outreach OPDs and Jaipur Surgical Festival, which has been a part of by IASGO, and it has been supported by ISPBA, Indian Association of Surgical Gastroenterology, Indian Society of Oncology, and all. Our publications have been, you can see that 2023 we had 11, then 9, and now 13 publications in 2025. And last time when we had presented our CCR, these were the two articles which we had said that we have completed and we are about to get published, and both have got published now this year. That is both, one is in the Curious Springer Nature, and other one is about the post-operative. One of them we will be discussing in the presentation today again. Our residents have been receiving repeated awards by the various international associations. Say Rishikesh and Akshat had gone to Singapore, and Harshal had got a travel bursary. Monir got from Jaipur Surgical Society. Vinay, our associate professor, had gone Korean liver transplant fellowship. Recent achievements have been by Rajiv Patil, poster presentation, Rishikesh best poster, rare case presentations, Akshat Dhanuka had presented best poster, and Adeeb had got a video abstract substituted for one of the best videos from the Pan India video presentations. So with that, from the Department of Surgical Gastroenterology, I would like my junior colleagues, my residents, to start. The topic is actually a girl who has had dysphagia for a long time. So I think we'll go step by step. By my first year resident, Dr. Akshay, will be starting the presentation.
A very good morning to all the faculties and the colleagues. I'll be presenting a challenging case of dysphagia in a young lady since childhood. She was a 25 years old female resident of Sikar belonging to middle socioeconomic class. She presented to us with complaints of progressive difficulty in swallowing to solid food for nearly 2 decades. Over the past 8 months, she had experienced postprandial vomiting 5 to 6 episodes per week. At the age of 3 years, the patient accidentally ingested a plastic bottle cap which was lodged into the esophagus and was removed endoscopically without immediate complications. Following the foreign body removal, the patient developed progressive dysphagia predominantly to the solid food, for which she required frequent sips of water during meals and was able to tolerate only soft diet. Over the past 8 months, Over the past 8 months, the patient had recurrent vomiting occurring approximately 5 to 6 times per week. Vomiting typically occurred 15 to 20 minutes after meals. The vomitus was non-bilious, non-projectile, and was moderate in volume with foul smelling. It contained mainly an undigested food particles. These episodes were occasionally associated with retrosternal burning and reflux symptoms. To summarize the HOPI, at the age of 3 years, the patient accidentally ingested a plastic bottle cap which was removed endoscopically. After about 8 weeks later, the patient developed dysphagia, which was predominantly to the solid foods, which required frequent sips of water for swallowing, which persisted chronically over several years without definitive treatment. In the last 8 months, her symptoms worsened significantly, along with postprandial vomiting that usually occurred 15 to 20 minutes after meal, around 5 to 6 episodes per week. Importantly, she had no history of corrosive ingestion, no history of odynophagia, no history of previous tuberculosis, no history of prolonged medication, no history of smoking, alcohol, or drug use. There was... Yes, sir? Odynophagia is difficult, painful swallowing, sir. There was no significant history of weight loss, and the patient was able to maintain adequate calorie intake through liquids and semi-solid diet despite of long-standing dysphagia. She had no history of gastrointestinal bleeding. She had history of seasonal bronchial asthma for which she was on Foracort inhaler. Her menstrual cycles were regular, no dysmenorrhea or menorrhagia. Personally, she was a vegetarian and her appetite was preserved, but her intake was reduced secondary to the fear of vomiting. Her bowel and bladder habits were normal. She had no addictions. There was no relevant family history of gastrointestinal diseases. Based on the history of progressive solid dysphagia, a structural cause was considered more than the primary motility disorder. Here I pose a question to the audience: what are the causes of long-standing progressive dysphagia? Yes, please. Okay. Yes. Yes.
A peptic structure or a foreign body structure?
Yes, exactly. Thank you. Based on the long-standing progressive worsening dysphagia, we consider the following possibilities. The most likely diagnosis is a post-traumatic benign esophageal stricture given the clear history of foreign body impaction in a childhood and the typical delayed onset after esophageal injury. A peptic stricture with hiatus hernia is another strong possibility, as chronic refluxes can lead to stricture over years, especially when the symptoms are long-standing and inadequately controlled. Infective or inflammatory strictures are less likely as there was no history of tuberculosis, immunosuppression, odynophagia, or systemic symptoms. Esophageal malignancy is least likely given the young age of the patient, very long duration, and absence of weight loss.
So tell me, can a peptic stricture like a GERD happen in a young child, like 3 years, 5 years of age? Does it happen in that young age?
Sir, thank you for the question, sir. Usually it occurs in a young age, not in the childhood, early childhood, but a young age, a peptic stricture can occur in a young. Long-standing progressive dysphagia may be due to structural, motility, inflammatory, or malignant causes. The most common benign structural strictures, especially peptic strictures due to gastroesophageal reflux diseases, followed by foreign body strictures, which is particularly relevant in this patient. Motility disorders like achalasia usually causes early dysphagia to both solids and liquids. Malignancy is uncommon in young adults and typically presents with rapid progression and weight loss. At the age of 3 years, the patient underwent an endoscopic removal of foreign body under anesthesia, which was uneventful. She reported for medical attention for the first time 8 months ago and underwent 5 sessions of endoscopic dilatation. Despite of repeated dilatation, she had only transient relief. Initially, the patient underwent an upper GI endoscopy and at an outside hospital. Following this, the patient received serial endoscopic dilatation for symptomatic relief. However, the patient continued to have persistent dysphagia. Therefore, a barium study was performed for further evaluation of the stricture. As the symptoms persisted despite of endoscopic management, the patient was then referred to a center. This was the first upper GI endoscopy which was done on 23rd of December 2024, which showed stricture at 28 cm from the incisor, and the scope could not be negotiated beyond the stricture. This was the last endoscopy which was done on 17th of March 2025. Between this, a total number of 5 endoscopies were performed. This showed a grossly ulcerated esophagus, narrowing at the lower third. A pediatric endoscope was passed. There was a large hiatus hernia. The Z line was present at 30 cm. Diaphragmatic pinch was at 35 cm. Dilatation was attempted with severogluteal dilator from 9 to 11. The stomach, pylorus and the duodenum were normal. Now, I would like to call my colleague Dr. Poorvi from Radiology, who will explain about the barium swallow report. Thank you for the question, sir. Sir, that shows probably a stasis of the food that has caused stasis of the food which was causing, like, it has caused the vomiting after a time of 15 to 20 minutes. Yes, sir. Yes, sir. We have shown it on the endoscopy. The esophagus was grossly dilated, sir, and then.
Sir, yeah. So the patient had a significantly dilated esophagus, which we'll see on the barium subsequently, and it was having persistent status in that area. So she was having a partial passage of the liquid content. So what happens is, whenever she would take any solid food, that will usually block this and she will have a vomiting. So vomiting was not a consistent feature. It used to happen only after solid food, which would block that passage, and then subsequently she will have vomiting. So that is how it was possibly explained. We can see it on subsequently the barium film which was done out. She was so for 20 years. For 20 years, not for a few days. It is long, yeah.
A very good morning to respected dignitaries, faculty members and dear colleagues. I am Dr. Poorvi Gupta, second year resident of Department of Radiodiagnosis, and I will be explaining the barium swallow findings in this patient under the guidance of Dr. Anandita Bose ma'am. So the barium study was performed outside, demonstrate a long segment approximately 5 cm smooth tapering with narrowing in the lower esophagus with proximal uphold of the contrast. However, normal distal flow is seen on the delayed images. These findings are suggestive of long segmental lower esophageal stricture, likely benign etiology. Also, gastric rugal folds are seen above the gastroesophageal junction, suggestive of hiatus hernia. Thank you. Now I invite Dr. Akshay to continue the presentation.
Coming on to general physical and systemic examination. On general examination, the patient was hemodynamically stable and was well oriented. Her BMI was 30.3 kg per meter square, indicating a preserved nutritional status. There were no signs of cachexia, pallor, lymphadenopathy or peripheral edema. Abdominal inspection was unremarkable. The abdomen is protuberant with symmetrical movement on respiration. There were no scars, dilated vein, pulsation or visible peristalsis. The umbilicus was central and inverted, and all the hernial orifices were normal. On palpation, the abdomen was soft and non-tender with no local rise of temperature. The liver and spleens were not palpable and no masses. Hernial orifices were normal on palpation. Auscultation and percussion findings were normal. The systemic examination was normal. The air entry was bilaterally equal with no added sounds. Hard sounds were normal without murmurs. She was conscious and oriented. So to summarize, a 25 years old female with a long-standing progressive dysphagia, predominantly for the solids since childhood, following a foreign body ingestion that was removed endoscopically with no improvement in the symptoms after multiple endoscopic dilatation, with unremarkable general and physical and systemic examination. So it was a refractory post-traumatic peptic esophageal stricture, non-responsive to endoscopic dilatation, associated with long-standing gastroesophageal reflux disease with large sliding hiatus hernia. So coming on to treatment options, Medical therapy has limited utility in the established benign strictures, and she has already undergone multiple endoscopic dilatation with suboptimal response. I would now like to invite Dr. Harshal from Medical Gastroenterology to comment on the further endoscopic management before we discuss the surgical options.
Good morning, respected teachers, respected dignitaries, and my fellow residents. I will be explaining the endoscopic management that were available for the patient under the guidance of Dr. Sandeep Nijavan, sir. The endoscopic management that is available for a patient with stricture, firstly, we have a balloon or a bogie dilatation of the stricture, which is a serial dilatation. Then we have, in refractory strictures, we have then intraluminal steroid injection, which is triamcinolone or mitomycin. Then we have an incisional therapy if the stricture is still not responding. A temporary stent placement can also be an option, but usually it is kept for malignant obstructions of the esophagus in carcinomas usually. Stem cell and tissue engineering therapies are not very conventionally used. The most important point for this patient was that the patient refused for further endoscopic management after undergoing 5 sessions of endoscopic serial dilatation under general anesthesia was a bit cumbersome for a young aged female. So that was the first thing that she refused for any endoscopic management further. Why endoscopic dilatation was alone inadequate? Long, smooth stricture, approximately 5 centimeters of length, with a mechanical obstruction beyond mucosal injury. Multiple dilatation up to 11 mm failed to provide sustained relief because repeated sessions are a part of endoscopic dilatation. Second was the persistent reflux secondary to large hiatus, and owing to her obesity with a BMI of 30 contributed more to the development of reflux and to the development of the peptic stricture. The associated risk of perforation and bleeding, which is a known risk with a dilatation of the esophageal stricture, and a lack of durable long-term outcome with endoscopic therapy, because her stricture was already classified as a refractory stricture. Further, we never knew how many sessions will she take to achieve relief that she wanted. And high failure and recurrence with endoscopic therapy is also known. In this case, the endoscopic management was also ruled out, and now I would like to call Dr. Mukesh to discuss the further options.
Harshal, before you move off.
Yes, sir.
See, when there's a large hiatus hernia present, which was almost about 5-6 centimeters above the hiatus, you have this sac, then wouldn't you say that treating this endoscopically would be incomplete treatment, because you're never going to treat the hiatus?
Yes, sir.
So, prima facie, one wouldn't really push for endoscopic therapy in a patient with a long lower esophageal sphincter and a large hiatus hernia. Plus, you said Savary-Gilead 9 to 11, I mean, you would accept that that is suboptimal dilatation. An optimal dilatation would be at least up to 15 millimeters Savary-Gilead, and then you can call it failure of endoscopic. This is suboptimal endoscopic therapy, number one. Number two, whether it is at all indicated in a situation when there is a significant structural abnormality like a large hiatus is worth considering before offering endoscopic long-term management.
So that is very right, but going in for a surgical option, initially a minimally invasive therapy is usually tried on, but the most important fact with this patient was that the repeated sessions and going up to a higher gauge of dilatation, we were not able to. When we dilated up to 11 mm, in the very next setting, it would again come back and we would have to start with 9 mm dilatation.
5 sessions is hardly anything. You just made the beginning. You have to go up. What we have done in refractory strictures is do it twice or thrice a week under GA and push up the caliber of bougies. Eventually, not in such patients, but in others, you have gone up to 18 millimeters also. And then after that, when there is a recoil, recurrence is adequate dilatation followed by a follow-up period and recurrent dysphagia within 6 months of completion of therapy. So what I would say was this was a suboptimal endoscopic therapy, which for various reasons of the patient not willing or otherwise, yes, couldn't be actually carried to its logical appropriate endoscopic conclusion.
Yes, sir.
Yeah, there are two very important points. One is that we could not reach 215 in spite of dilating because we have to follow a rule of 3. So if we actually start again, you have to start from 9, you end up by 12. So by doing repeated dilatation also we could not reach. So that was one point. And second point was that patient was not agreeing for repeated endoscopic therapy. In such patients you may require as many as 30-40 dilatations actually. So if the patient doesn't agree, so that's a contraindication for endoscopic treatment. And additionally, she has a hiatus hernia, as Dr. Saraswat has said, that it has also to be treated.
Yes.
Possibly when the dilatation was began, they were not able to pass beyond the stricture. So once they had, if you see the last endoscopy, they were able to pass beyond it, and they found that it is having a hiatus hernia also. So the referring doctor told specifically, once we have dilated so that the scope could be passed, we identified it had to be having a hiatus hernia. We did a barium, confirmed, and both the findings, and therefore we are referring to the surgery, and patient is still not willing. So I think everything was going against endoscopic dilatation.
Just a word about mercury bougies. We used to use mercury bougies, which the patient used to take home and do a self-dilatation. I don't know whether they are being used anymore or not.
Yeah, actually they were used in SMS. Nowadays, no, it is being used. It's a self-dilatation at home.
Good morning to all. Now this slide introduces the surgical management section, where I will describe the minimal invasive procedure choice of conduit and final surgical plan. Given the long segment benign esophageal stricture with progressive dysphagia, repeated endoscopic dilatations were attempted, but failed to provide a sustained relief. The patient was also unwilling to continue further endoscopic intervention. In addition, the presence of large hiatus hernia with significant reflux increases the likelihood of recurrence after dilatation. Considering the patient's young age and the need for a durable, definitive solution with better quality of life, we went ahead with surgery. All the baseline investigation were within normal limits. Hemoglobin and albumin level reflect adequate nutritional status. Preoperatively, the patient was evaluated through the multidisciplinary approach. A medical gastroenterology opinion was obtained to review the prior endoscopic finding and history of serial dilatation, confirming the refractory nature of the stricture. A pulmonology opinion was taken for respiratory assessment and optimization prior to the thoracoscopic surgery. The anesthesiology team evaluated the patient for fitness for prolonged minimal invasive esophagectomy and single lung ventilation. At this stage, the surgical options in these patients are two. One is retroesternal bypass using gastric or colonic conduit, which divert the food stream while leaving the diseased esophagus in situ. The second option is esophageal resection with reconstruction, which removes the stricture segment and restore the continuity. I will now explain these two options and explain why resection was favored in our patient. In esophageal bypass, the diseased native segment left in situ. This leaves behind a chronic, inflamed, non-functional segment which is not a definitive solution. The retained esophagus segment can act as a blind segment, leading to secretion stasis, recurrent inflammation, infection, mucosal formation, and long-term risk of malignant transformation. By contrast, esophageal resection removes the disease segment, providing single-stage definitive solution with better long-term outcome. In young patients, resection is performed because it avoids blind segment morbidity and offers the durable symptom relief. With advances in minimal invasive technique, esophagectomy can now be performed safely with reduced morbidity, making resection is preferable approach in our case. This patient has refractory benign esophageal structure for which esophageal resection with reconstruction is indicated as discussed. Traditionally, this could be managed by open esophagectomy, either transthoracic or transhiatal. However, this approach is associated with higher morbidity, more postoperative pain, and prolonged recovery. With advancement in technique, minimal invasive esophagectomy using laparoscopic abdominal phase and video-assisted thoracoscopic phase offer a clear advantage like less pain and fewer pulmonary complications. We went ahead with video-assisted thoracoscopic surgery because it reduces the post-operative pain and respiratory complication. The thoracoscopic camera provides excellent magnification of vital structure such as aorta and vagus nerve, allowing the precise dissection. Studies show faster recovery, shorter hospital stay with video-assisted thoracoscopic surgery compared to open thoracotomy. Once resection is planned, the next critical step is selection of reconstruction conduit. The stomach is generally conduit of choice due to adequate length and robust blood supply, and the need for only single anastomosis, making it technically simpler. The colon is alternatively when the stomach is unsuitable to provide sufficient length and resistant to acid, but is associated with native colonic pathology, redundancy, and altered bowel function. Jejunum also can be used, but a need for microvascular anastomosis make it restricted. The final surgical plan was video-assisted thoracoscopic esophagectomy with laparoscopic gastric conduit creation and intrathoracic esophagogastric anastomosis. Now I would like to invite my colleague Dr. Raghavendra from anesthesia team and to discuss the anesthetic challenges in this particular case.
Thank you, Dr. Mukesh. A very good morning to respected Emeritus Chairman Sir, all dignitaries, the faculty and my colleagues. I will now be discussing about the anesthetic challenges and management of this case. The young female patient planned for minimally invasive esophagectomy was sent to us for pre-anesthetic evaluation. The patient weighed 70 kilograms with a BMI of 30.3 kilogram per meter square, categorizing her as obese. Upon further assessment, the patient had a Malampatti grade 3 airway, which we anticipated is difficult for intubation. Our primary anesthetic goals for this case were prevention of aspiration during induction, hemodynamic stability, maintenance of oxygenation during one lung ventilation, and adequate analgesia. Some of the anesthetic challenges associated with the surgery were as follows. During induction of anesthesia, we were to strictly avoid gastric insufflation and use rapid sequence induction to avoid aspiration. There was a risk of difficult airway and problems associated with the placement of the bronchial blocker. The laparoscopic phase of the surgery was characterized by hemodynamic fluctuations and problems associated with reduced lung compliance and effects of pneumoperitoneum and the resultant hypercarbia. During the thoracoscopic phase of the surgery, there were challenges related to the positioning the patient prone with risk of displacement of various lines and tubes, challenges of mediastinal manipulation with risk of major vascular injury, and since the operative field was close to the pericardium, it predisposes the patient to arrhythmias, and majorly commencement of one lung ventilation and associated risk of hypoxia. For the operation theatre preparation, we had a cart containing all emergency drugs and cardiac defibrillator ready. We had a difficult airway cart consisting of supraglottic airway devices, a video laryngoscope, and a fiber optic bronchoscope. Since this particular surgery required one lung ventilation, we used an EZ bronchial blocker. The bronchial blocker is a device used for blocking ventilation to one lung, thereby collapsing it. This provides the surgeon with more space and a better surgical field. For thoracic surgeries, induction of anesthesia was done using rapid sequence induction technique with cricoid pressure to prevent aspiration. The right internal jugular vein was cannulated, and so was the left radial artery for invasive beat-to-beat blood pressure monitoring. The bronchial blocker was inserted and its position was confirmed using a pediatric fiber optic bronchoscope. The patient was put in a prone position intraoperatively before the commencement of the thoracoscopic phase of the surgery. The bronchial blocker is inserted through a standard endotracheal tube via an adapter which allows us to simultaneously ventilate the patient. The blocker is placed over the carina and its position is confirmed using a pediatric fiber optic bronchoscope. Inflation of the preferred side scuff leads to the blockage of ventilation to that side. One of the major risks during one lung ventilation is that of intraoperative hypoxia. A low partial pressure of oxygen in the intraoperative arterial blood gas analysis is one of the risk factors. Long duration of one lung ventilation and thoracoscopic surgeries is also a risk factor for hypoxia. For the management of intraoperative hypoxia, we administer 100% oxygen, check the position of the isolation device. We recruit and optimize the positive end expiratory pressure in non-operative lung. Continuous positive airway pressure is given to the operative lung, or intermittent 2-lung ventilation is done. The intraoperative hemodynamics of the patient remained stable. The patient was reverted back to supine position once the thoracoscopic phase of the surgery was completed. Double lung ventilation was restarted. An arterial blood gas sample was sent and all parameters was found to be within normal limits. Following this, reversal of anesthesia was done using injection Sugamadex, and extubation was done in a fully awake state after the return of all protective airway reflexes. Our post-operative goal for this patient was early ambulation and prevention of pulmonary complications using effective pain control and incentive spirometry. Now, Dr. Adeeb, third-year resident from surgical gastro, will proceed with the final surgical management. Thank you.
How soon does the other lung expand once you have deflated the occlusion device? And do you have to monitor that before you do? Similarly, you showed us a chart of the intraoperative hemodynamics.
Yes.
How about a similar chart for the intraoperative oxygenation, PaO2 pressures, that would tell us about the hypoxemia during the surgery?
Yes, sir. We've included saturation, oxygen saturation in this chart, but we haven't included the partial pressure of oxygenation because the arterial blood gas analysis was done only twice.
How about the expansion? I mean, there may be delay for some reason for the lung to expand. Is that a problem with one occlusion device?
Sir, usually it's not. Once we deflate the cuff of that particular side and resume 2-lung ventilation, it expands in some time. It doesn't take much time. Immediately. Yes.
Lung recruitment maneuvers are undertaken, and for monitoring the degree of saturation, oxygenation, the continuous monitoring of oxygen saturation is done, and intermittently blood gas analysis is done. Blood gas analysis costs a little, so it is done when it is deemed essential, when the oxygen saturation
I
is
think,
falling.
sir, adult lungs are having sufficient LS ratio, lecithin and sphingomyelin ratio. Surfactant are there. So unless the baby is premature, he is adult, it will immediately act and only made collapse, iatrogenic collapse.
The duration of collapse was
Immediately
only
as
during
soon
the
as air comes,
thoracoscopic phase.
It will
Thoracoscopic
shape.
phase, and recruitment maneuvers take care of it.
Surfactants are there on the alveoli.
And post-procedure incentive spirometry and other protocols, they also helped improve the work.
Good morning, respected faculty members and my colleagues. I will be discussing the final surgical management. Before playing the actual operative video, I will briefly show an animation demonstrating the key steps of the procedure for better orientation. The surgery was performed as a minimal invasive esophagectomy. First, the abdominal phase with laparoscopic port placement and gastric conduit creation was done. The patient was then repositioned to prone and VATS ports were placed. This was followed by distal esophagectomy and esophagogastric anastomosis performed in the thorax. We began with the laparoscopic abdominal phase. The stomach was mobilized from the greater curvature and short gastric vessels were divided. This was followed by pars flaccida division and lesser curvature mobilization. Dissection was continued towards the diaphragmatic pleura to free the proximal stomach. The stomach was then looped with an umbilical tape for traction, and finally the left gastric vessels were clipped and divided. The stomach was then divided using a linear GI stapler, creating a tubularized stomach for reconstruction, thereby completing the abdominal phase. We proceeded to the VATS phase. The mediastinal pleura was opened to access the thoracic esophagus. Following, the esophagus was further mobilized and site of the stricture was identified as a narrowed segment with proximal dilatation. The esophagus was opened to assess the level and extent of the stricture. The azygous vein was identified, clipped and divided to facilitate further esophageal mobilization and tension-free anastomosis. The esophagus was further opened longitudinally and extended proximally beyond the strictured segment to reach the normal healthy mucosa, following which the thoracic esophagus was divided and the strictured segment was resected.
A gastrotomy was created on the gastric conduit, after which an end-to-side esophagogastric anastomosis was performed, thereby restoring the continuity between the thoracic esophagus and gastric conduit. As you can see, the anastomosis is getting completed. Following the completion of the esophagogastric anastomosis, an air leak test was performed, which was negative. In this process, we instill air via the RT and we observe it in a saline-filled medium to look for any air bubbles. Here you can see the test is negative. We have previously highlighted the importance of air leak testing in our publication. Finally, the resected specimen was delivered out, completing the procedure. Now I would like to invite our professor and head, Dr. Akshay Sharma.
What type of sutures you use for air leak prevention?
Sir?
What type of sutures you use in anastomosis?
We usually use PDS sutures, sir. PDS, polyethylene textile.
I know.
Yes, sir.
I'm not asking about the type of material. I'm asking about the which sorts of, like intermittent or inverted sutures or regular suture, continuous sutures. What type of sutures you?
So in this particular case, we did continuous suturing.
Because continuous suturing may further lead to the stricture.
Yes, sir. But we have had a follow-up of this patient for the.
That is all right.
Yes, sir. There is a possibility.
That is the side effect of the continuous sutures. If you go for intermittent sutures,
continuous sutures, sir, this was a long debate earlier when all the patients who used to have a continuous suture was done with a continuous suture without interlocking. With the interlocking feature being taken into position, the sutures hold at its own place. So it is almost as good as an intermittent suture. The advantage of a continuous interlocking suture over an intermittent suture is that in stomach, which is a very vascularized stomach area, it prevents the bleeding. So that is preferred suturing method, whether you do a gastrojejunostomy, whether you do any anastomosis of the stomach. So if you do an interrupted suture, it has a risk of bleeding. If you do a continuous suture without interlocking, it is not of much use. So the preferred method is continuous suture with interlocking that we have used.
Sir, the blood supply I am telling this out of my experience with the tuboplasty. So previously we used to do continuous.
Yes, sir. Tube is very small as well. So possibly that is the site of it.
But the fundamentals remain same. But what you have said,
I'm happy.
Continuous and then intermittent.
I'm happy Ajamina is not here. Otherwise, you would say that vascular anastomosis. Of course, definitely they do it intermittent with interrupted sutures. That is the preferred method because less diameter. I think they feel that that is a better method to do anastomosis.
No, but even in transplants, vessels and ducts, a lot of people do continuous. So I don't think there is any evidence to say whether interrupted or continuous has a higher stricture rate. The only soft evidence is that stapled anastomosis in bowel has a higher stricture rate as compared to a hand-sewn anastomosis.
From pediatric surgeon
only.
Sir, the blood supply of esophagus is segmental. Upper 1/3, lower 1/3 and middle. So it is not like that you cut from anywhere an anastomose. You should take care of blood supply also. Otherwise, chances of necrosis of anastomosis are there. How did you manage that?
Sir, our gastric conduit was based on right gastroepiploic pedicle, and we did the resection was done just at the level of thoracic esophagus, sir. So the supply from the cervical was maintained, sir.
Upper 1/3,
and even thoracic.
Upper 1/3, lower 1/3, or middle 1/3?
Sir, middle 1/3 we did it.
Middle 1/3 was saved.
We did resection at the middle 1/3, sir.
It was resected.
Yes, sir.
Okay.
First thing, I don't agree. Sorry. I don't agree to most of the surgeons. That is my drawback. So, one thing is, you can have any vascularized structure. As long as you have a vascularized structure, doing an anastomosis is always safe. So, one thing. Now, if you see the video again, we had divided the esophagus at one place. If you see that video, we have divided the esophagus at one place and then we have gone proximal to that because that area was unhealthy to us. I know that might not be strictured. I know that might not be a narrowed area, but that was not healthy. So I had gone up again, I had gone divided it proximally and then circumferentially divided the esophagus and did an anastomosis. That was a healthy area. So that is the most important thing. If you have an unhealthy area, anastomosis is not recommended.
Like any other tubular structure, the only precaution which we have to take is that we don't mobilize it extensively. So otherwise, esophagus, ureter, they don't have a named blood vessel, but the small blood vessels, as long as the area where we are doing the anastomosis is healthy, not involved in fibrotic process, and we haven't done extensive mobilization proximal to that, interfering with its unnamed blood supply, there should be no cause for concern.
वैसे भी ह्यूमन बॉडी इस तरह के सर दो वास्कुलर स्ट्रक्चर्स को मिलाओ तो कोलेटरल सर्कुलेशंस डेवलप हो जाते हैं एंड इज वेरी डिफिकल्ट अनलेस टू मच मैनिपुलेशन इज डन विद द वेसल्स. दिस इज व्हाट आई फील.
Post-operatively, as Sir has said, we had to take all the precautions in the post-operative period. The patient was in ICU, but as usual, I again say most of the people will not agree, but we start oral feeding on day one. And now we are progressing. Post-repulse we started at 6 hours, and post-major surgeries we started at 6 to 8 hours, almost always for last almost 12 years now. And so we started her on oral feed on day one, as you can see it on the video. And as Sir was saying, that anesthesia point of view, post-operative spirometry was very mandatory for her, that she is able to lift her balls in the post-operative period on day one. And we did a contrast study basically to see what was the controversial issue, that whether the stomach empties, and the other thing is sometimes the tube that you have made from the stomach that dilates, how much is it occupying. So we could see that there is a good anastomosis, there is no leak, and the stomach is emptying. We can see the pylorus and the contrast going beyond it in that. And subsequently the patient after that, so this is a controversial video that she's taking liquid. So actually a resident has taken a liquid diet on day 4. A video she should have been shown taking idli masala dosa, that would have been better. Day 4 she was taking all normal diet and with a good mobilization, and on day 4 after her normal diet everything was normal. Biopsy had revealed it to be non-malignant and inflammatory stricture as expected. And we have a follow-up now almost for 8 months now, and last follow-up was a week back, telephonic conversation, and you will be surprised at what she was asking. She was supposed, she's got her marriage fixed now after the surgery, and she was going for a marriage, and she called me up just to ask, marriage mein sir tala bhuna khana to kha sakti hu na? So I was happy to answer that question. Yes, she can, and that has improved her quality of life.
क्या समस्या थी, क्यों ऑपरेशन कराया तुमने?
वो मेरे खाने में दिक्कत होती थी, मैं खाना नहीं खा पाती.
अच्छा, तुम्हें कब पता चला कि तुम खाना नहीं खा पाते?
3 साल की थी, तब से पानी के साथ ही रहती थी.
3 साल की उम्र खाना खाने नहीं खाती. अच्छा, तो अब 24-25 साल की उम्र में जाकर तुम्हें कैसा लगा कि ऑपरेशन कराना चाहिए? किसी ने सलाह दी तुम्हें?
नहीं, सलाह नहीं थी. मुझे वोमिटिंग होने जाती थी खाना खाते ही.
तो फिर आपका ऑपरेशन कब हुआ था?
1 अगस्त.
1 अगस्त को ऑपरेशन हुआ था. तो ऑपरेशन कितने समय बाद आपने खाना शुरू करा?
अगले दिन.
ऑपरेशन का दूरबीन से हुआ था या सीधे से हुआ था? दूरबीन से हुआ था. और उसके बाद में आपने अगले दिन खाना शुरू करा, तो कितने दिन बाद छुट्टी हुई थी? फिर तुम 4 दिन छुट्टी हो गई थी, फिर घर पे जाकर आराम से नॉर्मल खा पी रहे थे?
हाँ, फिर पूरी टीम को बहुत
ऑपरेशन में बहुत से लोगों ने बहुत सारी बात है. आप लोगों ने इसमें इतनी ज्यादा आपने मेहनत रखी, आपने हिम्मत रखी, विश्वास रखा, जिसको भी हम आपके विश्वास को सफल कर रहे हैं. ऑपरेशन कहाँ पे कराया तुमने, कौन से हॉस्पिटल? महात्मा गांधी हॉस्पिटल में कराए थे. बहुत बहुत धन्यवाद. मुझे अच्छा लगा. तो आप स्वस्थ हो, खुश रहो, स्वस्थ रहो हमेशा. क्या समस्या थी, क्यों?
So that was the last video. So in concluding remarks, definitely esophageal strictures. Most important thing is the VATS esophageal resection has been reported in 0.5 to 2% of the cases, and long-standing strictures required surgical intervention in almost 10%. Endoscopic dilatation may not be always be successful, and we could not find in literature a patient having a long-standing stricture for 20 years and then being reported repaired by a VATS procedure. So we've already written that article, and it may get published in coming some time. And I would like to thank, of course, the management, the team, the anesthesia team, medical gastroenterology. So the team, actually, I would like to emphasize here that anesthesia time, when Kaushal was giving anesthesia, Dr. Avinish, Dr. Vijaya ma'am, both were standing over there. That is the backup. How can that young man hold the problem, deal with that problem? I think the 2 elder people standing with him was a basic thing. When we were operating initial, that was in supine position. Subsequently making in prone is actually a difficult task. Of course, surgeons will understand, Dr. Rajgovind sir will understand, and surgeons will understand making it from supine to prone with all the lines inside is definitely a difficult task. And our team, Sattuji, Gloria ji, staff, Rajesh, they did a huge task to have everything in place, not even an artery line get removed. So that is a definite difficult task. And of course, medical gastroenterology team, Dr. Nijavan was in backup. He told that endoscopic dilatation, he gave us the confidence that what you are doing is correct. Actually, डर लग रहा होता है, तो मैं जो करूँगा कहीं गलत तो नहीं हो रहा है. And of course, support thanks to him, pathology team. And जैसा मैं residents को कहना चाहूँगा, हमारे residents ने presentation बनाया, they showed it to me, they felt it is good. उन्होंने मुझे दिखाया, मैंने कहा खराब है, मैंने अच्छा करा, I made it better, but when we showed it to Dr. Kapoor showed इसमें भी खराब है, फिर he improved it, and then we realized अभी भी हमने बहुत अच्छा बना लिया, इससे क्या होगा, and we went to और जयसवाल साहब ने पूरा का पूरा चेंज करा दिया. So I want to emphasize, what you are doing is correct, but your seniority makes a difference. Have faith in your seniority, have faith in them. Thanks to all the teachers and the patient and the family members for this.